Ladies and gentlemen, it's a great pleasure to open this VLU webinar, which is very much focused on the management of the sub-ulcer plexus. And it is my pleasure to start the meeting. I'm being Lowell Cabinet for the afternoon stroke evening, depending which part of the world you're in. And it's my great pleasure to ask Professor Rashad Bishara to talk to us about this sub-ulcer plexus. Rashad, over to you.
Thank you, Professor Alan Davis. It's really a great honor and a great pleasure to participate in this educational activity. Thank you, Dr. Victor Kanata and Dr. Lowell Cabinet for this precious opportunity. I'm going to talk about, here we go, the efficacy of ultrasound-guided foam sclerotherapy for the healing of venous leg ulcer. I'm Rashad Bishara, vascular surgeon from Egypt. I'd like to share with you this example of a 32-year-old male patient who works as a security guard, obviously a lot of standing every day. He gave a history of venous leg ulcer for 3 months. He had no history of DVT, and he underwent a duplex scan, and the duplex scan showed a patent and competent deep venous system, and it showed an incompetent dilated great saphenous vein. This is really a straightforward case, and this patient underwent ablation of the great saphenous vein, and we all know, according to the EVRA trial, which was published in 2018, we know that ablation of the great saphenous vein or stripping of the great saphenous vein would reduce the time to complete ulcer healing, and this patient actually had his ulcer healed within the next 3 weeks. However, 2 years later, he returned with a recurrent venous leg ulcer in the same location. This time, his duplex scan showed a perfectly ablated great saphenous vein, nearly non-existent. The distal part of the great saphenous vein was competent, as well as the small saphenous vein, and the deep venous system showed no abnormality. It was patent and competent. However, at the site of the ulcer, there was this incompetent network of veins. We call them ulcer veins in our practice, and we see this network of ulcer veins of varying dimensions in the majority, about 70-75% of patients who present to us with open venous leg ulcers. So this patient was treated with standard wound care. He had compression in the form of multi-layer, short strap bandage, and he also had ultrasound-guided foam sclerotherapy of the incompetent network of vein underlying the ulcer. Now, I'd like to share with you this second example of a 45-year-old female patient. She had a 2 years history of recurrent little ulcers in her gaiter area. She had a history of DVT 10 years ago, and her duplex scan showed a post-thrombotic occluded left iliac vein. The superficial venous system was competent. The deep venous system, although the femoropopliteal segment showed some post-thrombotic changes, but it was actually patent. And near the ulcer, she had a large incompetent perforator. So here is how she was treated. She had iliac vein recalcification. This image shows that the iliac vein is completely occluded and replaced by a large bunch of collaterals. And this is the final image following reconstruction of her iliac vein using 2 stents. She also had wound care. She had compression therapy. And also she had ultrasound-guided foam sclerotherapy of the ulcer veins, including the incompetent perforator, but the incompetent perforator was not targeted individually. This was followed by complete healing of this ulcer. Now, the technique of ultrasound-guided foam sclerotherapy for the ulcer veins is widely practiced today. One of the earlier publications was that of Dr. Ronald Bush, and he called this terminal interruption of reflux. The question remains whether those patient ulcers healed because of the ultrasound-guided foam sclerotherapy or because they only had good care in the form of compression therapy, wound care, etc. So we set up to conduct this multicenter randomized control trial. we had the great honor of Professor Alan Davis supervising or overviewing this study, together with one of his team, Mr. Joseph Shalhoub. And this was a randomized controlled trial comparing ultrasound-guided foam sclerotherapy plus standard care versus standard care alone. Our protocol was quite simple. A patient coming in with an open venous leg ulcer would have a duplex scan, and if this showed venous pathology, including the incompetent network of vein underneath the ulcer or in the vicinity of the ulcer or incompetent perforators, he would have an informed consent and then randomized into one of those two groups. So our inclusion criteria included patients with open venous leg ulcers who had a duplex scan showing venous pathology, including the refluxing network of veins or incompetent perforators, and the exclusion included young patient, pregnant ladies, ischemic legs, absence of ulcer veins, there was nothing to inject, or difficult ulcers greater than 2 years duration or greater than 20 centimeters to 20 square centimeters. Standard care included compression therapy, wound care, ablation of superficial flux if present, and recolonization of the deep venous obstruction if appropriate. And the foam sclerotherapy was conducted according to a standard method of Tessari. So identification of the ulcer veins, injection of polydocanol, a total volume of 5 to 10 millimeter per session. Most of the patient had only one session. Exceptionally, a patient would have 2 sessions, and associated incompetent perforators were not targeted individually, but were treated as part of the refluxing network of veins. Following foam sclerotherapy, the patient had compression bandages, etc., as usual. Now, the outcome was primary outcome, which is time to complete ulcer healing. Secondary outcome, the rate of ulcer healing, the number of ulcers healed at various points in time, and venous clinical severity score and quality of life assessment. Here are the results. Both groups were equal at presentation, except for the ulcer duration. The time to complete ulcer healing was significantly shorter in Group A, which received the ultrasound-guided foam, as compared to Group B. So it was 35, a median of 35 for Group A as compared to a median of 56 in Group B, which was highly significant. And the number of ulcers healed at any point in time was higher for the group which received ultrasound-guided foam sclerotherapy as compared to the group which did not. Now, the Kaplan-Meier curve shows that the ulcer healing time was shorter in Group A as compared to Group B. Also, the reduction in ulcer size was significantly faster in Group A as compared to Group B. Finally, the venous clinical severity score was similar in both groups before treatment, similar in both groups after treatment, but significantly different comparing before and after treatment. So the multivariate analysis showed that ultrasound-guided foam sclerotherapy had an independent effect on time to complete ulcer healing, and that the ulcer duration was only a co-founder in the relationship between the treatment of two groups. This was published in the Journal of Vascular Surgery in the issue of July this year. And we concluded that both groups benefited from the use of standard care of venous leg ulcer, and that the ultrasound-guided foam sclerotherapy significantly shortened the time to achieve complete ulcer healing. There remains some questions. Most important, does ultrasound-guided foam sclerotherapy affect ulcer recurrence? This is going to be the key question for our coming publication. And I would like to share with you those couple of examples. This is a patient who came in with an open venous leg ulcer. He had a duplex scanning of the ulcer area, which showed this incompetent network of veins. Then he had ultrasound-guided access. You can see the needle here, and you can see the backflow here. And again, here is a video of the backflow. And then another point of access was obtained around the ulcer. And then the foam was prepared using the Tessari method. And this was slowly injected into the network of veins. Sorry, it's a little slow. Otherwise, it's going to be painful. And this is what we get to see, the foam filling up the network of veins, which will collapse and become obliterated. That's a second example. Here you can see the network of veins and the backflow. Here is the injection of foam, and that's the foam again being injected to points of access. Here you can see the foam into the network of veins. And this is the last example. I think I still have a few seconds to go. So this is screening around the ulcers, which has to be done carefully and slowly to identify the incompetent network of veins around the ulcer. This particular patient had 3 ulcers. And this is the network of incompetent veins in the vicinity of the ulcer. And here's getting access into this network of veins using a high-frequency probe. And this is the needle in the middle of the vein. And then foam will be injected. Here we go. And then they get ulcer treatment. Again, here is the foam being injected, and compression therapy until the ulcer heals. There you go. Thank you very much for listening. Exactly 10 minutes.
Okay, Professor Rashad, thank you very much. And it's now my privilege to ask Dr. Ronald Bush, who may be regarded as one of the forefathers of sub-ulcer plexus injections, to discuss the issue. Ron, over to you.
Okay, thank you very much. Very nice presentation. Excellent results. I have a couple of questions. Did you ever consider just doing ultrasound foam guided sclerotherapy and no other procedures at that time to detect how long the ulcer took to heal? I think, if you don't do a lot of, it's hard to determine how effective. We know it's effective, but how effective it is, it can only be really determined by doing the procedure itself and not doing the ancillary procedures. And that's why we kind of came up with this concept, because this can be done any place in the world. You don't even need an ultrasound to do these usually if you have some kind of a visible vein around the ulcer. And actually, with an ultrasound, sometimes if the skin's really damaged, we actually do the access through the ulcer itself, which is sometimes more comfortable for the patient than going through the skin. When we did a lot of work in Haiti, we saw people with venous ulcerations, and that's how we came up with the idea of doing this percutaneously through a small reticular vein or even a spider vein, although it's a little bit more risky because you can get infarction of the skin with high concentrations of sclerotherapy in small veins. So ultrasound guidance is best, of course. But did you ever consider just doing this and then comparing it with conservative therapy alone without doing the adjunctive procedures, let's say of saphenous ablation or even of deep venous stenting? Doctor, have you ever tried that? Think about doing that.
Thank you very much for your comment. So just to give an example, a patient who's coming in with great saphenous vein reflux and open venous leg ulcer, and he has this network of veins. What you're suggesting, we treat the network of vein and we leave the great saphenous vein reflux untreated, and we see how long would that take for the ulcer to heal. We don't do this. But because of medical legal issues, if a patient with great saphenous vein reflux and no contraindication to strip it or ablate it, it's been very well shown in the EVRA trial that ablating or stripping the great saphenous vein will cause this ulcer to heal in the majority of patients. So so it's difficult to justify not doing this. The answer for this question, the straight answer is no. However, we do get referred some patients who are post-thrombotic patients who have a post-thrombotic femoral vein, for example, femoral popliteal segment, who have a patent iliac vein, and who have a competent superficial venous system, great saphenous vein and small saphenous vein. So actually, the only pathology that could be treated is the network of vein underneath the ulcer. There is nothing else we can do for those patients. And we know that if we treat those patients only with ultrasound-guided foam sclerotherapy of the venous leg ulcer, they will heal. Now, the question is, because those patients will not only have ultrasound-guided foam sclerotherapy, but they will also have standard care. So the question will come, what made the ulcer to heal? Is it the standard care, or is it the ultrasound-guided foam sclerotherapy plus standard care? And that's why we conducted this study, which obviously showed that ultrasound-guided foam sclerotherapy is helpful. It adds up on the standard care. I'm not sure if this an answer to your question.
Well, I can see your point. What we do, and usually we first see the patient when they present, we do the foam sclerotherapy at that time. And then in the United States, we have to pre-authorize for any kind of procedure such as ablation, et cetera. So by the time that the pre-authorization comes around, 80% of these ulcers are healed in 2 months, whether you do anything else or not. And we've also found that the ulcers that you treat with the foam sclerotherapy, sub-ulcer sclerotherapy, you don't get reoccurrences in that location. They just don't occur. And you may get a new one someplace. But for the typical venous ulceration at the medial malleolus, you must have an incompetent posterior arch branch of the saphenous vein. Those vessels you see, the ulcer vessels, are usually from the posterior arch branch of the saphenous vein. You must also have outflow, high pressure in the system where the vessel's empty, be it a perforator, the typical Cockett's or posterior tibial perforator, or even into distal vessels, if the perforator is not present. Just by doing the perforator itself, unless the foam gets into the sub-ulcer bed, will not heal an ulcer. You can do all the perforation, the treatment you want. It won't be as effective as foam sclerotherapy. So what you're actually treating, and when you do the ultrasound after doing the foam injection, you usually see the foam. If you really look carefully, you don't see the foam any place above the ulcer vessels, okay? But if you look around the ulcer, you can see foam in the region of the subdermal area. And the reason is because infarction of venous ulcers, for the most part, is a subpapillary plexus of vessels. Those you don't see because the pressure is so high that the foam doesn't get into the dermal layer. What you're doing, the whole theory of foam sclerotherapy is that you clot the vessels around the ulcer, and what you do is stabilize, make the venous pressure less, so that you can have normal AV perfusion at the ulcer bed. And we've actually seen this on some of our biopsies that we do around, especially if you have a question. Some of these patients, the older, have a question of squamous cell involvement. You can see squamous cell cancers in these as well. But if you do biopsies around the ulcer bed, you can see looks just like stasis dermatitis around the ulcer. There's nothing else. There's nothing peculiar about it at all. So this is related to a phenomenon of just pressure transmission. And so if you can decrease the pressure, you can heal the ulcer. And so I think, in my experience, this technique could be done without doing anything else, and it could have excellent results. Whether anybody's ever going to really do that, to compare that with just standard therapy without doing anything else, it's kind of hard, as you mentioned before. If they have saphenous insufficiency, they probably have other problems such as symptomatic disease, as well as maybe having this fatigue, other varicosities. So, but in my opinion, if you did this alone, the ulcer would heal, and you would not need to do anything else. Now, if they have deep venous obstruction,
may I interrupt you?
Yeah. One other thing, if they have deep venous obstruction, I think that should be taken care of as soon as possible, because the ulcer, even with sub-ulcer foam sclerotherapy, will heal faster. But you're not talking about reflux now, you're talking about pressure. There's a differentiation. Go ahead.
Yeah. Regarding great saphenous, if you leave great saphenous vein reflux and in particular, if the great saphenous vein reflux is going all the way down to the ulcer. I agree that you can make the ulcer to heal only by using the ultrasound-guided foam sclerotherapy and therefore diminishing the pressure. I agree with this, but I don't agree with the statement regarding recurrence. I think if you follow those patients long enough, and if you divide them in patients who were treated completely, that is ablating the great saphenous vein, and those who did not have ablation of the great saphenous vein, I guess that those who did not have ablation of the great saphenous vein would have a higher and sooner recurrence. But again, this needs to be proven and documented. Now you mentioned that you can do ultrasound guided foam sclerotherapy without ultrasound, and this might save time and expenses. I agree with this. In some patients where you can clearly see the vein with the eyes, but in the majority of patients, the skin is so hard and pigmented, and it's even difficult to get access into the vein, even with the ultrasound guidance. So in those patients, if you just keep puncturing the skin, like I've seen done without ultrasound guidance, I think you can cause a lot of damage to the skin. And also, there are some patients where you can have arterial signals very close to the veins. And if the needle goes into the artery, you'll just get a brush patch of necrosis and ulcer and get much worse. So I think as a rule, I think as a rule it has to be ultrasound guided. Sorry, Prof.
I'm just going to stop you both there for a minute, because Malay Patel's got a question, and it was something I was going to ask you, Rashad. What concentration of foam do you recommend, and what agents have you got experience with?
Thank you. That's a very important question. We do with polydocanol. We actually don't have experience with the other ones, and we tend to use a lower concentration, not a higher concentration. That is 0.5 to 1% polydocanol, mostly 1% polydocanol. Also, we don't inject a large quantity. I think the default, I would say, is 5 milliliters, and then we observe the filling of the network with the ultrasound. And if it's not well filled, we can inject another 5 milliliters. So it's 5 or 10 millimeters, but mostly 5 milliliters.
Because my question to you, while we're waiting for any others from the floor, is, and I'm sort of coming from a bit to the same place as Ron Bush. I've always wanted to do the study where you literally just inject foam and don't subject the patients to compression versus compression alone, because if we look at certainly very hot countries and other things where compression can be difficult, I do wonder whether you could actually just get away with doing the sub-ulcer foam sclerotherapy with just putting an ordinary dressing on it rather than subjecting the person to compression. Rashad, do you have any comments on that? And then I'll ask Ron for his
Yes,
thoughts.
I'll ask Dr. Ronald Bush. Now, if you inject foam in the sub-ulcer veins, and many of those patients have very fibrotic skin, and the subdermal layer, it's very fibrotic, and the veins are wide open, and it's even difficult to compress them with the ultrasound probe. So if you inject foam without compression, do you think you get occlusion of the network of venous plexus? I don't have this experience. We always use compression. So what do you think, Dr. Bush?
I don't think compression is necessary. What we do, we don't compress them. We actually just use try to do wound care. We teach the patient how to flush it with a 3cc syringe and a 30 gauge needle. They can actually go right above the ulcer and flush. It works pretty well. Try to breathe if we can when they're there. But we use a non-sticking dressing on an Adaptic or Xerofoam gauze, and a little bit of Curlex, sometimes a mild compression, let's say 20 millimeters, sometimes just an H wrap, but we don't do compression. No, I don't think it's necessary, because what you've done when you've done the sub-ulcer injection is you have an internal compression dressing, which is much more effective. What are you trying to compress with the external? You don't need to. If you clot the vessels up, you have an internal compression dressing. And we also use Sotradecol, preferably. The reason we use Sotradecol is based on histological studies. Sotradecol is 3 times more effective than polydocanol for these larger vessels. you have more intimal damage to the endothelium. Polidocanol, a lot of times you just see, I mean, it can work. 1% polidocanol, yes, sometimes we use that. But we feel much more comfortable with 1% Sotradecol and getting one-time injection, and that's it. Polidocanol, sometimes you need to inject another time. We see them back in 2 weeks. But we use Sotradecol since it's widely available here in the
Ron,
US.
just to ask you, because it's obviously something that is often debated. What solution do you get your patients to irrigate their wounds with?
Saline or Vosh, they can use Vosh in a little syringe, and it works very well. It's like an angiojet.
Yeah. Okay. Do we have any other questions from the audience? Rashad, is there anything that you would like to add and have about a minute to sum up?
Well, I think the comment of Dr. Bush is very relevant. I think that could be another study, whether compression is needed or not. But of course, Dr. Bush is using STD, which is a different solution. I'm not sure whether it's because it's a different solution, it does not need compression. But that's a very important comment indeed. And I think we have a question from Dr.
Garani. And this is a question to both of you. Do all ulcers have a sub-ulcer plexus?
Yes. All venous ulcers. If you
all
don't,
venous ulcers, yes. I apologize for my statement. Venous ulcers have
if you don't see a sub-ulcer plexus, then you don't have a venous ulcer, period.
Okay.
Question to Dr. Bush. You mentioned that if you occlude the subvenous ulcer plexus without occluding the incompetent perforators, the ulcer will still heal. Is that what you meant?
Yes, it's true. Yep.
Yeah, I agree with this. I agree with this very strongly.
That's the first reason I came up with the tears technique. The patient I saw had a large ulcer for like 6 months. We injected a perforator. She came back in 6 weeks later, it was healed. Perforator was wide open, but the vessels under the ulcer were occluded. Yeah.
Yeah, absolutely.
And just to ask all of you, because it's certainly in the UK, it's topical. Do you think that the foam sclerotherapy injections should only be given by a medical practitioner, or can they be given by ancillary medical staff?
I think you have to be very competent in ultrasound to do it, and I don't know. I mean, I think it should be by a practitioner myself, not a mid-level, but a physician that's skilled in ultrasound-guided sclerotherapy. Because that's just one point in healing the ulcer. There's other things you must do also to keep out of trouble.
There's also a question that's just come up asking about what temperature you use the polidocanol or other screening agents. I must admit, in my institution, we just do it at room temperature, but I will ask Dr. Bush and Professor Rashad if they do anything different.
Room temperature.
Room temperature.
Right. Well, if there aren't any more comments from the floor, I found that to be an absolutely fascinating discussion as to how we may go forward with respect to management patients with venous ulcers. I quite like the idea of doing a trial with compression and subulcer plexus versus subulcer injection alone. I've heard obviously what Dr. Bush has said, and I actually agree with him that my intrinsic bias is that you don't need to have the compression. Victor, do you want to, well, I thank obviously both of the speakers for taking part in this. Victor, do you want to just put up the advert for next week's VLU lecture? And then once we've seen that from Victor, I would very much like to thank Victor. You're on mute. It's just.
I'm sorry. The next lecture will be on the next day, the same day that we have before. We will have I've been trying to
Just as a comment from me while we're waiting for Victor to finish that, there was a question about varithena and polydocanol. No, my own view is that there is no advantage over physician compounded foam. And if you look at all of the evidence, I would suggest you can do it as cheaply as possible and you don't need to have the additional costs of varithena. But that is very much my own personal bias.
And if anybody has questions more, they can go to incderm.com and we'd be glad to answer them. That's incderm, derm.com.
Ron, thanks very much.
All
Victor,
right.
have you got that slide that we can show or not?
I'm trying to upload, but I was going to tell you that the case will be what is a JIT versus thrombus, extension, and how to treat. We will talk about regarding about glue and trouble with the glue, and this is the final idea for the next stop. It didn't come out the picture. Sorry, we will
Okay,
see
no,
all.
Victor, thank you very much, and thank you all very much for attending, and particularly thanks to Professor Rashad and Dr. Bush. Thank you all very much.